weren't, resulting in uninsurance at 1 year instead of 60 days. All right, so these are some of the things to think about around improving coverage. And now let's switch gears and think about, okay, so even if these coverage gaps are filled, we know there's some populations that are going to be left out of this. States can do meaningful things to make sure that doesn't happen. But even for those that the coverage gaps are filled, is it going to improve maternal health? And the theory here is just that Medicaid coverage is going to promote timely use of needed health services, and that's going to result in improved health outcomes. There's lots of reason to believe that this is going to be true. There's a lot of rigorous evidence from other populations that Medicaid does these things. It improves access to care, it can improve social determinants like reducing evictions, and it can improve health outcomes. But some of the evidence from pregnancy in terms of Medicaid impacts is a little weaker than it is for other populations, and there's very little evidence from postpartum people. So we don't have direct evidence yet about the impact that this is going to have, but in theory it could work. However, there's a few caveats that I want to just mention here. One is that these extensions don't address preconception coverage and healthcare, which is absolutely critical. You cannot fix everything that's happened in someone's life, at the point of prenatal care and postpartum, right? So thinking about making sure that people have their chronic conditions managed and are entering pregnancy as healthy as possible continues to be critical, and is definitely losing focus as so many people turn postpartum. I just want to turn your attention back preconception, just to really keep that in our minds, because it continues to be really critical in terms of improving maternal health. The other is there's a lot of things that can go wrong from just getting coverage to actually getting the timely quality care that you need. And generally the healthcare payment and delivery models around pregnancy they're not designed to promote care continuity. They're not as designed to have handoffs between OB care and primary care or specialist care. There's very little accountability for postpartum people. No one knows whose responsibility are postpartum patients after 6 to 8 weeks, right? Like it's not OB anymore, but how does primary care get involved? There are major issues in actualizing this and translating this postpartum coverage to effective clinical care models. And another caveat is that we know social determinants, including poverty and structural racism, are critical drivers of maternal health that aren't necessarily, while Medicaid can help with social determinants, it doesn't necessarily follow just from coverage that those will be improved. There's things Medicaid can do to help those features, but they have to be intentional, and there have to be layers of initiative on top of coverage to make those changes. So following this, I'll just preview, that same study I was showing you that we found that big reduction in postpartum insurance. If we look at some of the other outcomes we can see in the existing survey data on postpartum, for postpartum people, we didn't find any changes in other outcomes. We didn't see any differences in postpartum visits or in long-acting reversible contraception or breastfeeding rates or depressive symptoms. So even though there was this big reduction in postpartum uninsurance, we didn't find any changes actually in any of these other outcomes. It's a very limited set of outcomes, but it's what's in the survey. And there could be a couple explanations for this. One could be that these caveats that I just mentioned matter, and coverage didn't translate to improved healthcare access. But this is during COVID. It's a unique period, and it's a policy. This wasn't a policy targeted at postpartum people. It just happened to come down through this continuous coverage provision, right? So maybe it'll be different when we're really intentional about covering postpartum people. Another explanation, it could be the data. This isn't a huge data sample size, so there's low statistical power. It's a short follow-up period. It's only about 4 months postpartum, so we're only really capturing an extra 2 months of coverage. Some of these outcomes happen before the 60-day cutoff. Usually postpartum visits are before that, so why would extended coverage matter? And a lot of contraception is received before that. And these are also a limited set of the target outcomes that we might care about for coverage. So I'm showing this just out of full disclosure. We looked at these outcomes. We didn't find an impact of the policy, but there's some good reasons why that might be the case. But I think it does suggest to us that we shouldn't just be assuming that coverage is going to translate into these improvements, right? And now that adoption of these extensions is universal, I think that we should really be shifting some of our focus, both as researchers, policymakers, practitioners, on trying to inform and evaluate the state and managed care plan initiatives and innovations that are going to be layered onto these postpartum extensions. So the coverage is there, but we should be thinking of that coverage as a platform for other interventions in key areas that we think are going to improve maternal health. So the question is, how should states prioritize these efforts to ensure that extended coverage actually translates into improved health? And I'm going to talk about just, my final little bit of this presentation on some of the data collection efforts that I've been running with my colleague Heidi Allen on trying to inform these efforts, to try to think about, okay, what is it really that these beneficiaries need? What are the programs that states should be focused on layering onto these extensions? And one of the things that we came across when we were initially starting to think about this is that because we weren't focused on the year postpartum, right? This wasn't considered part of perinatal period or health. There isn't really data collection efforts on postpartum outcomes, right? We have some really awesome maternal health data infrastructure in the US. There's, the birth certificate data, so you can get individual level data on every single birth in the US. That's how we know about low birth weight. That's how we know about preterm birth rates. That's how we track all those birth outcomes. And then there's also the CDC PRAMS, which is a survey that's run a couple months after birth, where we get all kinds of indicators on health behaviors in pregnancy, preconception care, contraception use, drug use in pregnancy. A lot of that comes from PRAMs. But these don't include the postpartum period, right? Birth certificates end at birth by definition, right, as birth outcomes. PRAMs has very limited information on postpartum outcomes. We don't have a follow-up, right? We don't know about what's happening after that period. So we added to this sort of maternal data infrastructure and developed a survey that's designed to do just that. So it's called the Postpartum Assessment of Health Survey. I'm going to make a little plug for it and then show you some results from it. And this is the first large-scale multi-state survey on postpartum health in the US. And what we do is we do a 12 to 14-month follow-up to that CDC PRAMS, right? So we already have this existing survey that's asking people about preconception and pregnancy. Why don't we contact those respondents again a year after birth and ask them, what has gone on in the year after birth? How is your health? How is your healthcare access? What have you been dealing with in housing and food security and other social determinants? And the survey is linked to birth certificates and PRAMs, includes all these things I just mentioned. And we ran this following a cohort of 2020 births, and we'll be launching it again with 2024 births very soon. And just to give you a sense of where we're doing this survey, we have partners in Michigan, Virginia, New York City, Kansas, Pennsylvania, Utah, New Jersey, and we're adding 2 new sites for 2024, including Hawaii and the District of Columbia. And one thing I just want to say about this is that these are partnerships with these state health departments where they're, developing the survey with us. We're developing the protocol with them. This is built into their sort of maternal child health bureaus within their state health departments. So this is really a survey that we're doing with these jurisdictions and not just in them, which I think is just an important distinction of having the decision makers and the players sort of at the table and involved in research and in the data collection enterprise from the beginning. And the survey goals are, we want to build momentum and will among these partners to act to improve health. We want to create a new scientific resource, and I'm happy to talk to anybody about how you can use the data. Yeah, Colleen? Yeah.
It's a representative sample of all births?
In those jurisdictions. Yeah, live births, all live births. Yeah. And we wanted to show the CDC and show the states, hey, you can do this. You can collect postpartum outcome data. It's feasible, it's useful, here's what you get for it. So there's this potential for institutionalizing that outcomes collection. And we think that states are particularly going to be interested in this at this time where they're also implementing these postpartum extensions, where they have to think about how do we prioritize investments, and also how do we evaluate those investments that we do make, because there isn't really great data to do that. And just, I guess, to Colleen's question, I'm not, of how this actually works. So basically, all of the states or jurisdictions draw a sample of their, live births from their birth certificates. It's a random sample. The PRAMS contacts those moms that are selected 2 months after birth. They're given a chance to opt out of our survey, and those that don't opt out, we contact 12 months after their birth and give them a $45 reward for doing so. So the sample size, because we have in this 2020 version, we had 6 states, is about 5,000. We have 8 states, it's going to be about 7,000. this is really, it's powerful, rich data, but like something that really needs to be, I think, national. It needs to be state year level for it really to be, really useful for policy evaluations. And I just want to show you a little bit of what it shows, and some of the things it might point to when we're thinking about these postpartum extensions. So this is just some results from a paper that our team published in Health Affairs last year. And what I'm going to show you are some different indicators for health outcomes, for social determinants, and healthcare access. And I'm going to be comparing the Medicaid, those who had Medicaid at birth, to those who had commercial insurance at birth. And I'm going to do that not because they're comparable. This data I'm showing to show you, they are comparable. Look at some of these differences, right? Much higher rates of younger people that are enrolled in Medicaid, much higher rates of people of color enrolled in Medicaid, a lot more unmarried people in Medicaid. They aren't comparable, but the point is that the commercially insured indicators give you a kind of benchmark to even have a sense, right, of what's going on in the Medicaid beneficiary population, and kind of helps you size the estimates that you see in comparison to this, the commercially insured population. So I'm just going to show you a few, and then we could, I'd be really interested in hearing thoughts about, what do you think of in terms of interventions when you see some of this outcome data? And I'll tell you about some of the things that I see. So this is showing health outcomes at 1 year postpartum. So the gray in all these graphs is always going to be commercial, and the blue is Medicaid. And you see, much higher rates of poor or fair self-reported health in Medicaid, and much higher depression symptoms and anxiety symptoms. So these are based on, PHQ-2 and GAD2 screeners at 12 months after birth. So this is sort of untreated, unmanaged symptoms of depression and anxiety, much higher among Medicaid. So, pointing to things like, how can we think about integrating parental depression screening into well child visits, thinking about the age-old question of how do you improve access to mental health and behavioral health care within Medicaid, also so critical for this population. How do you develop the network of providers who are going to accept Medicaid as a form of reimbursement? We can look at healthcare access and use. So here are some indicators such as, whether you have a usual source of care. Almost 42% of Medicaid beneficiaries saying they don't have any usual source of care 12 months after birth, right? So no connection to a primary provider just a year after birth. And then also much, lower rates of primary care, lower rates of dental care, and higher rates of ED use, which again is a very familiar pattern if you study the Medicaid population before, that you see lower rates of preventive care and higher rates of emergency department use. So this points to thinking about things like, home visiting as a model, going to people where they are rather than requiring them to come in postpartum, person-centered care models, thinking about how to support those transitions to primary and specialty care. And the dental piece is also like a really critical one around perinatal health. Comprehensive dental benefits are not something all states offer within Medicaid. There's a lot of state variation. And that's something that, it could be just there could even be just improved benefits for pregnant and postpartum people, but leveling that sort of playing field in terms of dental benefits as well. In terms of social determinants of health, we see higher rates of unstable housing, quite high rates of intimate partner violence reported among Medicaid beneficiaries, almost 7%, higher rates of food insecurity, almost 1 in 5, and high rates of financial strain. So really pointing to some of these social determinants of health as critical for intervention in the postpartum period. And there's things we can do about those things too, right? There could be better data sharing to make sure that all Medicaid beneficiaries are enrolled in WIC. There's like abysmal, enrollment in WIC among Medicaid beneficiaries. And part of that's because like the state, they just like don't share the information of who could be eligible. Like simple things like just sharing that information to get everyone enrolled could be critical. Social determinants of health screening, housing and employment supports, violence intervention services, all of these things are important to think about. Another one that is really interesting and starkly different between Medicaid and commercial is tobacco use, right? So smoking and tobacco, nicotine product use, much higher in Medicaid. And what we see when we track the data that we have from preconception to late postpartum is that the relapse rate for the Medicaid beneficiaries is so high. And then the overall rate is lower and the relapse rate is lower in commercially insured. And pregnancy is this period where so many people quit smoking. It's this remarkable opportunity for long-term smoking cessation. And so this is a huge missed opportunity to have that the level of smoking go up this high, almost back to preconception levels. So smoking cessation, another thing that could be, a major priority and focus of postpartum Medicaid extensions. And the last one I'm going to show before I wrap up, and this isn't about a postpartum indicator, but I think it's really critical in thinking about people's ongoing interaction with the healthcare system. And this is looking at mistreatment experiences in childbirth. So this is comparing Medicaid and commercially insured and the rates that they report being mistreated during their delivery episode. So these are things like being shouted at, being scolded, having your privacy violated, having treatment forced on you that you didn't want or withheld that you really needed, being ignored. And the rates are, much higher among Medicaid, although they're, problematically high, I think, in both populations. And thinking about these mistreatment experiences in this critical moment of childbirth and how that is going to affect trust and willingness to engage in the healthcare system, not only in the postpartum period, but potentially for the rest of someone's life. And so these experiences are also an important target when thinking about how do we engage people postpartum. Are you going to want to go back to a provider that you feel mistreated you? No, you're not going to want to do that. So I think this is also another critical piece of the puzzle. And there are solutions, proposed around, how can we measure, incentivize more respectful maternity care in the U.S., promote midwifery-led birth centers, Medicaid reimbursement for doula care, and also just addressing the really intense segregation of maternity care in the U.S. There's huge segregation in where you give birth, according to your insurance status, and therefore according to your race and your income, and very big differences in quality across those centers. All right, so, and then I want to just point out, for example, doula care is one of these things that, could be a potential intervention to address, something like mistreatment in childbirth. And there's going to be a lot of opportunity to evaluate these types of interventions. So this is actually an outdated map, but it's the only map I could find. It's a little bit outdated, but showing all the states that are currently, implementing or actively reimbursing doula care under Medicaid. And Illinois did this in 2022, though I've heard from my meetings that it's not really happening. New York, did this as of January 2024, and we're also having a lot of implementation issues. But there's all of these, initiatives that are going to be going on over the next 5 years around these postpartum extensions that represent this great opportunity for learning across states so that we can figure out what is actually going to work and what doesn't work and make sure that our investments are actually going to make a difference in improving maternal health. So with that, I'll just share some takeaways and then we'll get to discussion. One, these extensions have been widely adopted with this goal. They are very likely to reduce postpartum uninsurance. It's going to be very dramatic, but the residual insurance that remain is going to be around this non-qualified immigrant group, which we should really be concerned about. And then now that this adoption is near universal, we should be changing our thinking around some of these other initiatives that can be layered on top of these extensions to really address health-related social needs and improving healthcare delivery postpartum. So in other words, the work is only beginning. It's exciting that these extensions are in place, but we're going to need a lot of folks thinking about how to do this right and evaluating these initiatives to make sure that these investments are wise. And if they aren't, to chart a new course and figure out what's actually going to work. So with that, thank you, and I look forward to a robust discussion.
I appreciated your talk. I have a question here. I think I heard you say that Medicaid and their mental health deaths were a big part of the Medicaid
and substance
component.
use.
Right.
Yeah.
So can you speak more about that? What kind of death? Suicide? What does it look like?
Yeah, it looks like suicide and overdose is what it is. And one thing to keep in mind, and I didn't show this, I thought about it, but these maternal deaths, particularly the rise in mental health and SUD related deaths among pregnant people, they track those rising in general among the reproductive age population, right? So if you looked at a plot of the mortality for reproductive age women over that same time period, it's also increasing. It's not something only happening among pregnant people. So it's important to keep this in mind as the maternal mortality crisis is happening against a backdrop of a sort of national crisis in sort of deaths of despair or mental health related and SUD related deaths. So that's another way to like come at the problem, is to say, you know, if we addressed that from, you know, just the sort of younger and middle-aged population and those deaths that are increasing, we would also have a meaningful impact on maternal mortality. It's a different way to come at the problem, but yeah.
I have a question that's really similar to that. I was also struck, it was like one of your first graphs, which showed like reasons for, and I think it was maternal mortality, not pregnancy-related deaths.
Yeah.
But I suspect, again, it would look similar. That, again, what was most striking is the mental health and substance use disorder. And so basically what you're saying, though, is that suicide and overdose is the cause of death. And so what that, so I have a couple questions then related to the survey, given that finding. So you have different measures like intimate violence, but I was curious if you asked about substance use disorder. You have depressive symptoms, but I was curious if you asked about that. And then I was also just as another question related to that, when you think about interventions, it does seem crucial. I mean, we have all these initiatives in Medicaid trying to get people connected to, you know, medication-assisted therapy when you have addiction. You know, I don't know, like our states creating some intervention delivery models specifically for birthing women for postpartum period, because this is such a important opportunity to intervene when you know there's been prior addiction. And then, I mean, there's all these questions that come up, right? Like the decriminalization. So are they also being surveilled? You have child mistreatment when there's, you know, we've had such a bad history of criminalizing women who use drugs. And so is this also part of the picture that it's hard for them to use because then they interface with the criminal legal system?
Yeah, these are all great questions. So for the first one, we ask about use of different substances, and reporting was very low. And you know that we've now, and so you know that could be, it's a survey. We are doing it in partnership with government, and it's clear that we are doing it in partnership with government, which I think can influence response on some of these outcomes. We are asking a lot more in our revised survey about substance use disorder. We're framing it differently, and rather just like asking about substance, asking about diagnoses of substance use disorder in the past, asking about unmet needs related to that. We have significantly revised the sort of mental health and SUD section of the survey because it was just so clear that that was the sort of alarm bell. And we also have expanded, you know, instead of just a PHQ-2, we have the PHQ-7 and the GAD-7 so that we're actually going to be able to look at severity of the symptoms. So we're trying to add richness to this because it, I think, is somewhat superficial in the first survey. So the point is very well taken, and hopefully we improve it. And there are always going to be issues about response around these things that stigmatize. There's fears, especially for pregnant people and people with young children. And the second point, yeah, I think I feel like there hasn't, so you can see, for example, CMS released a toolkit for, you know, these are some of the things states could do around postpartum Medicaid extensions, and mental health is there, and SUD is not there as much as it probably should be. And so I'm not, you know, sure exactly why that is, but I think there hasn't been, like, I think, as much coupling around all the work that's been done already on SUD, mental and behavioral health, and Medicaid, and these extensions in particular. And another way to even think about it is, like, you could be evaluating the effects of these extensions and looking at it by subgroups of states according to how, you know, their pre-existing policies and initiatives around mental health. like they don't need to be layered on top. They could be underneath, like they're serving, already to help increase the efficacy of these extensions. And so, yes, yes, it matters. But not all these connections have been made, I think. Yeah. Yeah. Oh, yeah. Oh, whoever has the microphone, I guess, Debbie.
Hi, thank you. So interesting and such great work. I'm curious if you can say a little bit, or if you know if this is something you looked into with the different policy moments, like when emergency Medicaid for pregnant people, or even the special levels of pregnancy coverage went into play, and looking at what caused the most recent changes and what we might do going forward, sort of who the different groups are that may have political power. And the thing that comes to mind for me is that, back in the day we didn't maybe have EMTALA, but nonetheless, most people with a pregnant person showing up at the hospital in labor are going to take care of that patient. And now with EMTALA, they're required to. And that's expensive. So if they don't get any coverage, if the patient has no insurance, they may try to send her a bill, and she may or may not be able to pay it, but they're out a lot of money for taking care, right? A delivery is an expensive thing. Whereas we don't have EMTALA for outpatient care. There's no right to be treated if you show up and you can't pay, and there's no requirement that providers take Medicaid, except FQHCs and certain types of providers. So making sure that the program is generous enough and is well resourced in its implementation is going to require some political power. So I'm curious if there's any lessons from history that we could be taking going forward. Sorry, multifaceted.
That's a big question. Yeah. I mean, I've made, maybe I already made the point in my meeting with you, but in many ways, this was an easy policy change to make because it's pretty cheap actually. The cost of just the added coverage is not that high because most postpartum people are healthy. It's an easy sort of amendment to an existing program where there's already established deservingness and an established history of that beneficiary group, like in both red states, blue states, and the coverage piece itself I think is the easy part, and it's all these other investments, like what states are going to be serious about translating this coverage into improved health. And it is really not a given because for the reasons I said, but like this postpartum year it's not established clinically, as I think in terms of like what are the effective models to actually ensure continuous care. Like there aren't precedents for it working well, just because of different scopes of practice between specialties, and the fact that most maternity care providers are OBGYNs and not primary care doctors or in the US. So there isn't like that obvious transition point. And so, yeah, I mean, I guess I don't know if this doesn't really answer your question, but I do think when I say like the work is only beginning, I feel like this is like the easy part, this extension of coverage. Like that doesn't have that, we don't have to get into any like turf wars about how are we going to pay people to actually make sure that they do that handoff, or who's going to actually be accountable for the outcomes of people beyond 6 to 8 weeks, or like beyond the bundled payment period. How are we going to actually do that? Like those are the thorny questions, and they're more politicized, I think, than the coverage extension itself. Yeah.
I have some questions going back to one of your initial slides, and 3 of them. 1, is there anything on Asian, if you will, that very broad group of Asian maternal mortality? Number 2, when we're looking at differences, and I was thinking Indigenous, but this could apply to any group. When we're looking at that, are there differences between the urban and rural settings that we saw in the later slide?
Yeah.
And then 3rd, differences in age, different types and reasons. So for instance, like when you see Black mortality being so high for Black American women, do we also see particular ages that are more susceptible, more sensitive than others?
Yeah, great questions. So the first point, yes, I think there are some reported maternal mortality rates for Asian populations. I mean, maternal mortality is a rare event, right? There's only about the rate is high, but there are only about 700 deaths per year in the country. So I think, as happens, is sometimes there aren't reported rates for some populations. But I think from what I have seen is that the Asian rate is sort of similar to Hispanic. But that will again vary by state, and what the composition of the Asian group, is going to look like is going to vary by state. So if you are curious, looking at state maternal mortality review committee reports, they're very rich, and they, will dive in deep into, and often report, all the information that they have, regardless of sample size. Where sometimes the CDC has rules about, error that they're willing to accept, but the MMRCs will often report regardless of sample size restraints. So that's that point. The second is, yes, rural, so maternal mortality and severe maternal morbidity is higher in rural areas. It's another priority population for maternal health. You may have been aware of a lot of rural hospital closures, especially maternity ward closures in rural areas in recent years. So again, there are a lot of concerns about what to do about that.
Reservation, non-reservation.
I haven't seen that.
Okay.
Yeah. But yes, yeah, I haven't seen that. Yeah.
And the third one on age?
Oh, age. Generally older. And the nexus, there is one CDC report where they report maternal mortality by age and race, I think just for white, Hispanic, and Black. But that nexus of older birthing Black people, it is the rate is very, very dramatic. And that's, chronic conditions and other complications are going to be more likely among older folks. Yeah. Yeah, hi.
I'm Gabriella.
I can hear you fine. I know everyone's far away. It's like, you could have sat at the front tables. No one ever wants to sit at the front in case the speaker attacks. Yeah, okay.
Okay. Hi, I'm Gabriella. Outside of my work here at Crown, I help lead a national resource center focused on the intersections of gender-based violence, trauma, and behavioral health. And so a lot of violent deaths we know intersect with intimate partner violence from a lot of the great work of Jackie Campbell and others, right? That's become very apparent. And so something that, as we look at Medicaid expansion, and you've noted, is that we have a huge opportunity to really have an impact on these violent deaths.
Yeah.
And that gender-based violence piece needs to be threaded throughout, right? Because if somebody is, if their suicidality is attached to intimate partner violence, but it's only being addressed by a mental health model versus a more holistic intersectional model, right? Then we're gonna miss it. Yeah. And so I have so many questions, but I'm not going to say them all now. I'd love to connect with you separately. But one of my questions is whether in the survey, people's mental health, substance use, and other experiences are being asked kind of in these silos, or whether there are any questions. Okay, let me back up. We have found with our surveys that if we ask people just about their mental health or just about the substance use, then it's no. But if we asked, has a partner or ex-partner ever coerced, pressured, or forced you to use, or made you use more than you wanted, then all the yeses start coming in. And part of this, I think, is something that we found in a recent national survey that we did, where 80% of people who had experienced abuse during pregnancy had false allegations around their mental health or substance use made in order to jeopardize their child, their connection to their child, and try to get their child removed at birth. And so for this reason, right, so many people experiencing this, immediately it's no, because I'm already being threatened with this and having my child removed, right? So that's one question. It's in the survey, is it kind of topic, or are there any questions that kind of get at some of the intersections between gender-based violence and violent death?
These are great points. I would love to connect more on, thinking about survey design and particularly, these intersections. And we actually probe a lot more on intimate partner violence than we did in the first survey, where we just ask, whether they've experienced it. We ask more about reporting and like actions taken, like supports they wish they had had that they didn't have. Like we've added all of those questions to just add more to the story, because what do you just do with just the indicator? It doesn't give us a sense of that. But in terms of connecting it with mental health and substance use disorder, I think we do what you say we shouldn't do, in that we do ask it in silos in that way. So I'd love to hear more. Maybe we can connect after this about how to do that better. Yeah.
And then one more question, which is that I imagine that people's experiences in improved health outcomes around these violent deaths would have a lot to do with the policy environment in their state, including things like mandated reporting and all of that. So are you all planning kind of policy reports and recommendations and all of those things after you analyze what you gather?
Yeah, I mean, so we prepare reports for the states that we work with. So we do a lot of work with them on like designing, fact sheets and other products that they'll use internally to, to their sort of higher ups, or, they have opportunities to try to influence like the governor, or, to get grants. So we're working with the jurisdictions that, are partnering with us in that. We've been doing that work with them, which is also, just as a side note, like incredibly time consuming. I think probably, I don't know what you have in mind if you're thinking like something more of a national, something like with more broad recommendations that comes out of it. Is that what you're imagining?
And even thinking about comparing how some of the policy differences, right,
Yeah,
around
right.
like in one area,
Yep.
how that translates to some health outcomes.
Yeah. We will do some of that. It's limited, like we have, only the states that we have, and smaller sample sizes. But yes, we hope to do that. And when we have the both years of data, we can also aggregate them to increase our sample size. But yeah, thank you for these comments. I think the time is too. Yeah, I'll be here. I'll hang out. Yeah, come. Thank you so much.